Morning, everyone. While we're pulling up the slides, I'll introduce myself. I'm Danielle Ramo. I'm a clinical psychologist and senior director of research at Hopelab. And I am honored to moderate our panel on interventions delivered via social media. I used to be faculty in the Department of Psychiatry at UCSF, and in 2018, I joined Hopelab. And I just want to take a moment to tell everybody what Hopelab is. We are a social innovation lab. We build behavior change tech to support adolescent health and emotional well-being. And we're part of the Omidyar group, supported by Pam and Pierre Omidyar. If anyone's interested in finding out more about Hopelab and what we do, you can feel free to go to our website, hopelab.org. And we are actively interested in using social media to understand how best to support health and well-being of young people. We're working on at least 2 interventions right now that are being delivered via social media. So it was absolutely perfect for me to be able to moderate the panel today of an outstanding group of 3 faculty who are doing work across the spectrum of populations and health areas around intervention on social media. So we'll be hearing from Karhai Chu, Megan Moreno, and Emily Vraga over the next hour. And we really purposefully didn't want to give you 3 quite similar talks, but rather wanted to allow you to understand how much breadth is happening in this area. Could I have the next slide, please? Things are a little slow for me, so I'm hoping that it's changing for everyone too. Here are the objectives of our intervention session today. And I'd like to draw your attention to 3 aspects of the work on intervention delivery via social media. The first is that we know a lot about how to change cognitions and behaviors in person and even online. There have been a few decades of research in this area, but to understand how best to deliver intervention via social media is an entirely new animal. And it is complicated by the fact that the social media platforms themselves are changing quite dynamically. So I'm looking forward to hearing how these panelists have been able to adapt to the changing environment of social media in their intervention delivery work. I already mentioned that we explicitly chose the panelists to support a wide variety of populations and health conditions. And I also have asked the panelists to highlight some of the opportunities, but also the challenges that they might be facing in delivering interventions via social media, and hope that when you're thinking about questions and applications to your own work, you can also feel free to ask the panelists what unique challenges there are around delivering intervention via social media. I can highlight that I think a lot about ethics and about logistics and about the media not being the same. We can't control it as well as we might be able to in another platform. So those are some of the things I'm thinking about and look forward to hearing from the panelists now. And with that, we can move on. We're going to have the panelists each share for about 10 minutes. And then I'd like to ask the audience to please feel free to ask your questions actively and dynamically in the chat. And then we'll have a moderated Q&A at the end where we will pull from your questions. If your question doesn't get answered, there is a chance to ask panelists more questions in the networking session that will follow immediately after this session. And with that, I'd like to introduce our first speaker, Dr. Karhai Chu.
Thanks, Danielle, and thanks for this invitation to PRISM. I have more thanks to give, but I feel like with 10 minutes, I'm going to try to just jump in and go straight into the talk that I'm going to give. So just to give some context, my background, my training is actually as an engineer. I come up through computer science, so I've worked more with technology earlier on, and then for about the past 8-9 years, I've been working in public health. So that's a lot more postdoctoral training in health behavior, and it ties in with social media because I sort of see both sides. And what I really want to point out for what I want to talk is 2 things. One, From the technology side, I wanted to sort of walk through a few decision-making, right? About the differences in technology, the affordances, what interactions work, what don't, and what it really means. And then I also want to sort of bring in from the health behavior side, methodology and how we sort of apply that in social media research. So the first slide that's here, what I want to show is really platform decision, right? Where there's so many choices. We've seen Facebook research, Twitter, Instagram, Snapchat, Reddit, you know, across the board. But what I try to constantly emphasize is, why are you picking a platform, right? I think with Instagram, you might argue it's image-based. It's a younger demographic. You might kind of like go in that direction. But I think even when you look at that type of research, there are still a lot of differences in it. So what we're seeing in these two graphs, we took data from Twitter on the left and Instagram on the right, looking at, I think, 11 different keywords, all the same for both platforms. They're all nicotine related. And what we wanted to see were what types of clustering was happening, what type of, were there these groups that naturally showed up when people discussed these terms related to nicotine. And we did everything identically on both platforms as far as timeline, terms that we used, and types, the interactions. And you can see right off the bat, they're not the same, right? You don't see the same types of grouping, the same types of interactions on Twitter as you would on Instagram. Twitter is much more separated into these groups. So you might argue that there are more echo chambers happening if you start diving into the data, right? And what that means, why are there different groups, even though they're really discussing all of the same thing? And similarly with Instagram, why is everything sort of very centralized? There's two sort of outlying groups in the pink and green ones, but the majority of the conversations are all sort of surrounded around the same larger group on Instagram. So aside from the different platforms, it's also important to kind of see how they, what types of interactions are allowed, right? With Twitter, you have a single click, you can retweet things and it just spreads. With Instagram, there's different ways. There's third-party apps that allow you to sort of share things, or you can mention other users. But it's very different when in reality, and you can see that difference. So I think that has a lot of implications for research, right? When you're just thinking, how do I study spread? I think you want to take a deeper, like a more serious conversation than, well, let's just go on Twitter and look at retweets, right? Because it's going to be very different. If you look at Facebook and look at sharing, you look at Instagram and look at tagging others, those are also different types of spread, but happening in very different ways, just based on the platform, the demographics, and what the features are allowing. So that's for me, sort of coming from the technology side, I see very different ways that things happen. So the next slide. This is an example we looked at with Facebook, specifically around HPV vaccinations. The context for this study was, it's published in Vaccine. We were looking at a pediatric practice locally that had been promoting HPV vaccinations, but then it got attacked. A lot of anti-vaxxers kind of jumped in and all started spamming the sites, giving it negative reviews, and really bashing the pediatric practice. And what we were interested in is, given Facebook's sort of environment and the fact that you can type out paragraphs of information and not, 140 or 280 character tweets, is that different? And we can see with Facebook that you do sort of get a little bit more clumped together, but then we can actually go in and look at these different topics. And this is sort of my second part, where I'm bringing in the methodology, right? I work with a lot with social network analysis. So my interest is in sort of these clusters and where these bridges are, and if there are sort of these connections made. And you can sort of see in this particular slide, there were differences in the topics that people sort of came in with when they were really about promoting anti-vax behavior. And you can see it's, there's sort of this green group, which is about the moral transgressions, vaccines cause death, autoimmune diseases, versus homeopathic remedies and chemicals and harm and personal stories. And then there's the personal choice, freedom, government group, right? And we looked at a lot of these profiles, and there are Trump supporters and Bernie supporters. There's young and there's old. It sort of spans across the board, but then we can sort of see these clusters. And the point that I really want to emphasize here is, if you take a step back, it's less about the platform. we came in wanting to know about networks and wanting to know how these clusters came up. And I always feel like that, to me, has stronger impact. If you come in with a question that's platform agnostic, that's interaction agnostic, and really have your, whether it's health behavior, or for me as a methodologist doing social networks, whether I'm looking for particular things, then I think you can sort of make your case a lot better about what platform to use, how you're using it, and really what features you're showing. Because I think if you sort of jump in and said, we just decided to use Facebook because it was convenient, I think you get a lot more pushback. And then your study sort of gets a few more question marks. The last slide. This one, so aside from we looked at Facebook, Instagram, and I wanted to point out Twitter, we looked at similarly looking at the nicotine keywords. And again, you sort of do see these clusters again. So it shows, it's sort of what we showed before 2 slides ago. What I really wanted to point out here was, aside from just the methodology and the platform, you can do a lot more. So what we're seeing here are the black dots are what we categorized as bots, right? And we know bots are a problem, especially on Twitter. If you want to do a health study, you can have all these great data, but at the end of the day, who's posting this? Or is it really a 17-year-old kid who's vaping, or is it just a bot that's posting that sort of information? Coming from computer science, I think I get a lot of questions about how do we find out if it is a bot? Can we do it at scale? And I think there's a lot of interesting research with that. But what I sort of take coming from the health behavior side are really sort of these echo chambers and these groups of people that discuss the same topic with groups and friends that are just like them. And with the additional sort of piece that bots are also like that, right? You're going to get groups of bots that all just bounce around messages to each other. And when we look at this, what we were trying to find were not exactly which account is a bot, right? We gave it a probability and we said, do they show up as a group? And for us looking at trying to develop an intervention for nicotine use for vaping for kids, we can find in this particular case 2 groups. In this, we labeled it green and blue, that were heavily loaded with bots, right? So even if we're thinking about, we're not sure if this is 100% a bot or if it's 100% a human, we can get enough data at scale, given the amount of quantity on Twitter, where we can sort of see, wow, there are a lot of probably bot accounts in this group. And you know what? So when we develop our intervention, we're just going to chop that arm off. And similarly with the green side, we can kind of dive a little deeper and see if it's really problematic, or if it's, if it's just our algorithm not really smart enough to figure out is sarcasm a bot? Is this not? But given that large scale of numbers, I think social media sort of allows us to say, well, wait a minute, we're seeing way too many here in this cluster. And if we're going to spend the amount of time the next year, the next 2 years developing intervention, there's really no return on investment to just spam it all out there and expect this return where, half of them are actually bots and we're not really getting what we want. But sort of taking this first step, and given the technology that we know, and then the audience segmentation that we can do on social media, it really kind of allows us to be very precise how we target the population for interventions. And I think that's all I'm going to say for now. So thank you again, and I appreciate any questions or comments later on.
Thank you so much, Karhai. That was amazing. Really appreciate the efficiency with which you stayed within time. It keeps us going for the whole rest of the day. You highlighted a unique challenge around designing primary prevention interventions via social media, which is that if somebody puts out messaging, even if it's health supportive messaging on social media with tags related to vaping, e-cigarettes, anything where there are quite a number of bots and frankly, all sorts of marketing related accounts on what may be not so health promotional foci, that poses a real challenge for spreading positive health information. And how I think how we ought to be thinking about that is still getting shaped. But there's no doubt that in the vaping world and tobacco world as well, that is very real, and I deal with it as well. So I look forward to seeing how you're going to handle it with your intervention work moving forward. And with that, let's switch to the realm of adolescence. And I'd like to introduce Dr. Megan Moreno, who is going to be talking about using social media for intervening on adolescent health.
Thanks so much, Danielle. It's a pleasure to be part of this panel discussion this morning. And I'm excited to share some reflections and some learning that our team has had in working in this space. I plan to briefly touch on the why of social media for adolescent health, some key learnings in the area of groundwork that we laid to do this work, and some theory and frameworks we use. And I'll end with briefly touching on an example intervention that we've been working on more recently. Could I have the next slide, please? So I'd like to begin with some key considerations in why social media provides so many opportunities for interventions with adolescents and young adults. And in the upper left, you see an image that represents health access. And one of the things that we know about the adolescent population is that they are a population that is among the least likely to seek clinical care from a health provider. I'll say it again, they're the least likely to seek care. And some of that is that as a whole, they're one of our most healthy populations, but they also have a lot of barriers to accessing care. And one of the things that's really interesting and has been shown in studies of adolescents is that even when they do seek clinical care, they're very unlikely to be asked about health behaviors and health conditions that are important to their prevention and their overall health. So we know that adolescents are less likely to be asked about things such as mental health and how they're doing, and they're less likely to be asked about health behaviors that are important, such as tobacco and alcohol use. So given that social media is nearly ubiquitous among this population, there's a lot of opportunities to enhance their access to interventions, to important health information, and patient education. In the slide, in the picture that is just to the right of that one represents reach. So I think that social media provides a lot of opportunities for reach, both in terms of interventions, as well as in terms of sharing your findings and what you've learned with social media, sometimes using social media as a dissemination tool to reach adolescents and their families. And it also allows us to reach into populations that are harder to reach using our traditional methods. So we can reach, maybe have easier reach into rural populations or reach adolescents that are not in traditional schooling settings. And then last, I'll just mention that social media is not one thing. It's really a complex toolbox that we can use in a lot of different ways. We can use it to recruit for interventions. We can use it to direct one-to-one message and communicate with our participants. We can use it to share information and understand what information they endorse or that they share themselves. So it provides this really complex toolbox for us. Next slide, please. So some of the groundwork that we did in starting to do work in this space is represented on this slide. And one of the key considerations for us was understanding the rules of engagement. And we did this work by doing qualitative work with teens and young adults to understand what would the ground rules need to be to understand their preferences for how to interact with us as public health researchers and as clinicians on social media. So some of the key things that we learned from that were that adolescents absolutely do not want us posting on their page, and that was one of their most concerning areas. And so we've built that information into all of our consent processes and all of our standard operating procedures that we never post directly and publicly on any adolescent's page. We also learned about post frequency. We learned about ways to handle when an adolescent posts something concerning, such as suicidal ideation, on their page, and how they're comfortable with us interacting with them. So that groundwork that we did has continued to inform the way that we structure all of our studies, particularly our intervention studies. For theory and frameworks, I'll assume that the work that you all are doing in health behavior has its own set of health behavior theories. But when it comes to social media, a couple frameworks that we've found very helpful are noted here. So the first is the Facebook influence model, which is represented in the lower right. This was a data-driven model that we developed using concept mapping technology. And we have used this to understand key components of social media that can be influential to teens and young adults. And that can help us both for seeking out what kind of information is already there and might be influential to teens, as well as developing approaches to share information in ways that can leverage those influential aspects of those tools. A second one we use is uses and gratifications. This is a much older theory, but really adapts well to the social media world and helps us understand how do adolescents and young adults select their own platforms, what are their expectations of how they're used and what gratifications they get, and ensuring that if we're selecting a platform for a particular study, that we're aligning with the user expectations and culture of that platform. And last, I'll mention that we also use affordances, building on the excellent information that Cara has shared. Affordances, as many of you know, are design elements that help users know how to interact with that tool. And I love the simplistic but really clear diagram down below that shows how the design elements of a button let you know that you should push it, while a light switch shows you just by its design that you should flip it. And so we think of that when we think about selecting platforms for interventions. So for example, if we are looking to do an intervention that really capitalizes on identity affordances, we really want to connect to that teen's sense of identity and help use the intervention to potentially have them change a behavior that's core to their identity, then we need to select a platform that has high identity affordances. So that might be illustrated by things such as the expectation to use your own name or a profile picture. So a high identity platform might be Facebook or Instagram, versus a low identity platform might be something like Reddit, where there aren't those identity cues and design elements. And last slide. And here I'll just illustrate an example intervention that we've been working on called Social Media Basics. So this is an intervention where the goal was to improve the access to and the timing of an alcohol intervention, with the idea of trying to time an alcohol intervention close to a change in alcohol behavior or an episode of problematic alcohol use. Our target population was community college students. This came from groundwork that we had done to understand that this was a group that had similar problematic alcohol rates as four-year college students, but typically did not have access to a university health center or a way to consistently be screened or provided interventions. And we also sought a population that was at higher risk. So all of our participants were screened and had an episode of alcohol use in the last 30 days and an episode of binge drinking in the last year. So the way that we structured this intervention, the social media was linked to a high identity platform. So we created connections with our participants with their consent on Facebook and Instagram. And we observed over a 9-month period for posts describing problematic alcohol use or escalation in alcohol use. And those would prompt us to send the patient into a randomized intervention. And the intervention was BASICS, which some of you may be familiar with. It stands for Brief Alcohol Screening and Intervention for College Students. We are fortunate to partner with a collaborator, Dr. Melissa Lewis, who has a lot of expertise in this validated intervention. And one last slide. And so we're looking at the feasibility and acceptability data right now for this intervention. Some of these key points were also brought out in Brad Kerr's poster presentation yesterday, but a key element was that we found that over half of our participants over the course of that evaluation of social media did meet criteria for the intervention and were randomized. And most commonly, we saw that prompt that suggested problematic alcohol use or escalation in alcohol use during the first couple months of the social media observation. So while we evaluated for 9 months, most of the prompts happened very early on. And most of our invited participants completed the intervention as well as the 1 and 6 month follow-ups. So we had high rates of folks who went in and completed the intervention as well as completed the follow-ups. And given that this entire intervention from recruitment to the final follow-up was done online, that gives us a lot of excitement and hope for what we might be able to do from what we've learned from this intervention. I'll conclude here and I'll look forward to further discussion throughout the panel and further events.
Thank you so much, Megan. That was an excellent example of how Facebook and other social media can be used as secondary prevention tools for adolescents. So if we think about mass messaging around changing cognitions or behaviors as being primary prevention, you were using social media to identify those who were at highest risk for things like alcohol and other substance use. And I've noticed, certainly in my work, which is also steeped in background in addiction, that young people are more likely to post things like alcohol and other substance use on social media than they may be to talk about it with their friends in person or with people like physicians or even researchers. So social media really does afford an amazing opportunity to identify those who are most at risk and in need of more direct intervention. Thank you so much. And with that, I'd like to introduce our third speaker, Dr. Emily Vraga, who's going to be talking about correcting health misinformation on social media. Emily, take it away.
Thank you, and thank you for inviting me here today. I am delighted to talk with all of you. Next slide, please. So what I wanted to start with is thinking about when we need to intervene. So this is a figure that comes from the Debunking Handbook, something I worked on with about 20 or 30 other people who are scholars interested in misinformation research. And I think this figure is really important because it demonstrates that certain interventions are more appropriate when misinformation is rampant versus when it's expected. So on the right hand of the figure, you can see that when we expect misinformation, the best solution is to pre-bunk, to try and give people information, accurate information, as well as explanations of potential misleading techniques, but not actually address any potential myths that might be out there. On the other hand, once misinformation already exists on social media and is prominent, if you could go ahead, please, what we need to think about is when we need to debunk. And there are a lot of best practices about that. And I'm going to be focusing on what we call observational correction, something that we think about specifically as applied to social media. Next slide, please. So what is observational correction? Observational correction occurs when you see someone else being corrected and update your own attitudes as a result. We think about this particularly in the realm of social media because social media has a couple unique features. When we think about correcting misinformation generally, we think about a single audience, the person sharing the misinformation. And that audience is really hard to reach. The person who's sharing the misinformation has publicly committed to it and is confident or interested in enough in that position to share misinformation. The really important part, though, is on social media, there's a secondary audience, a much larger audience, and that's everyone who is seeing that interaction. They're less involved in the misinformation, and so they might be easier to correct attitudes if they see a debunking immediately after. So we think observational correction works uniquely because, first, it's targeting people who are one step removed from this process, who are seeing a social cost of sharing misinformation, because no one likes to be corrected, especially publicly, but are not paying that cost themselves. And so their motivated reasoning, their tendency to counter-argue against correction might be lower. Second, the correction occurs immediately at the same time as the misinformation, at least after it's been shared for the first time. So the logic of social media means that when I comment on a post, that comment, that correction, is seen at the exact same time as the misinformation. We have seen this work across a bunch of different platforms and a bunch of different issues. So these types of corrections can come from algorithms. On Facebook, for example, the related stories algorithm can pop up stories that are explicitly stating the truth behind whatever the issue is. More recently, we tested this with a WHO information bot, something that we made up, but that could be utilized to respond to people sharing this information by posting accurate responses, and coming from the WHO has quite high credibility. That leads me to my second point. It can come from not just algorithms, but from expert organizations. So we've tested this with the WHO, the American Medical Association, the CDC, and when we see these expert organizations responding to misinformation, providing accurate information, and providing a link, misperceptions around the whole community tend to decrease. Lastly, this can also happen from ordinary users. This doesn't have to be relegated to social media companies and health organizations who have a lot of other things on their plate. ordinary users can effectively respond to misinformation, especially when multiple people do so when they provide a link. We've also seen this work across a number of platforms. You can see here examples from Facebook, Twitter, Instagram, and Facebook Live. Next slide, please. So what are some of the best practices we've discovered across our research? So most of this research has been done with Dr. Letitia Bodie, and we've done at least 8 studies at this point. And across them, we have several kind of best practices that have emerged. First, you need to rely on expert sources. So that could be the experts responding themselves, or it could be ordinary users who are linking to the CDC, linking to the WHO, linking to the AMA, linking to fact-checking websites. As long as they're providing accurate information and relying on an expert, that tends to be more effective. Second, repetition matters, especially for users. So if you see somebody else has corrected misinformation on social media, that doesn't actually absolve you of your responsibility. If we have 2 users responding, both providing additional information, that tends to be more effective. Third, and this is true not just of observational correction on social media, but correction in general, alternative explanations are really important. So if you tell somebody something's wrong, but don't tell them what's right, that leaves a gap in their memory, a gap in their understanding that they might fill with misinformation. And so telling them not just what is wrong, but what is right is incredibly important. Fourth, preemptive correction can work. So this means you don't have to wait for misinformation to be spreading. You can be sharing accurate information that responds to prominent myths in society, the pre-bunking that we talked about earlier, and that can be effective in reducing misperceptions. Fifth, there's a couple different ways you can do this. The one way we've talked about most is fact-based debunking. So telling people what the facts are on that particular issue. So for example, hot baths don't reduce your risk of getting COVID. But you can also tell people about the logic of the misinformation, and that might be more flexible because in that case, what you're doing is explaining the misinformation technique, not the facts of a particular issue. So for example, you might say a lot of misinformation relies on false experts, people who seem to have credentials that you would use for expertise, but really those credentials aren't applicable or are made up. That is something that is common across a lot of different types of misinformation. So knowing that might not just help you in the single domain that you're emphasizing, but anytime you see that misleading technique used across a wide range of health issues. Sixth, don't post stories trying to debunk misinformation. If you are posting something and saying, hey, watch out, this is false, a lot of people aren't even realizing that you're trying to debunk. Instead, people seem to assume that if you are sharing a story, you are endorsing it, even if you say the exact opposite. Finally, empathy can help and it doesn't hurt. So telling people it's okay that they shared the misinformation, or at very least, you can understand how that would happen, or it's easy to make that mistake, or it's very confusing, doesn't hurt the correction and its effectiveness, but might make it more palatable to everyone seeing that interaction and make it easier for you to correct others without feeling like you're getting into a confrontation. Next slide, please. So that leaves us with some open questions. First, who is going to produce the high quality accessible corrections? Now, it could happen just through linking to an expert organization, but that's going to be less effective than having a highly visual graphic, for example. And so we need expert organizations, we need journalists, we need people to be producing high quality corrections. Second, this is a community-based solution, but it's a very small community right now who is willing to correct others on social media. So some recent data suggests that around 25% of people say they have corrected someone else on social media, but around 70% of Americans say that this is something they like, that they appreciate it, that they in fact see it as people's responsibility. So how do we motivate people to engage in this corrective work so that we have a robust community to respond to people who are sharing misinformation? Other questions that remain are, how do we decide which misinformation to prioritize? There's a lot of misinformation out there, and in some cases it's going to be easier, and in others more difficult. How do we decide which misinformation we should focus on? What are some of the secondary benefits of correcting misinformation? I've been focusing largely on misperceptions and maladaptive behaviors, but Could it change our trust in scientists, for example, or our trust in social media platforms? Finally, can we use this in combination with other efforts, for example, news literacy, that can help people recognize misinformation and be more responsive to correction when it's there? And as you can see from the poll results, that 25%, for us, it's only 18. So what can we do to make sure all of us are kind of taking part in the important work of correcting others, knowing that it can be effective? That's all that I have for you. I look forward to talking to you more in the Q&A.
Thank you so much, Emily. That was excellent, and I feel called to action. It reminds me that there is so much energy around misinformation right now, and clearly with documentaries like The Social Dilemma and a lot of talk about how quickly misinformation is spread, there's a lot of concern about that out there and not a lot of clear and tangible solutions. It's also easy to say, oh, the journalists have got this, they're going to be able to correct misinformation. And I am seeing a lot of journalists on platforms like Twitter doing that quite actively. But what it sounds like you're saying is that we all, especially folks who are here at PRISM, have in part a responsibility to be part of the solution, and that it might be easier than we think. So if those of us who are actively on social media took a little bit of that time that we spend posting organic things and instead take a moment to correct some misinformation, we can be part of this intervention that will actually make a real tangible dent in some of the misinformation concerns out there. Thank you so much. All right, then for all three panelists, I'd love to open up the Q&A. We've had some great questions come through, and I'm going to start with Karhai and ask you I'd like to ask all three of you some specific questions about the interventions themselves. And Karhai, I'd love if you could just talk a little bit about how you are thinking about designing an intervention now in light of the fact that there are so many bots out there in the health areas that you study, and you do want to try to reach as many young vapers as possible in your work.
Absolutely, and that's a tough question to answer. And I think the approach we've taken is sort of what I alluded to. And again, that's just a tool I have in my toolbox as someone who does social networks. We look at audience segments, right? And I think so vaping is a great example, I think, because there are different people that are pro-vaping and anti-vaping. But again, aside from that, we can look at specific groups, right? If it's a pro-vaping group, it could be small business owners that own vape shops. It could be, people who have successfully quit smoking with vaping. It could be just people that are curious. And what we do in kind of like looking at that and designing the intervention is that when we see those groups, we would target it differently, right? You don't use the same message. And I do think that's kind of a failing in public health. We tend to sort of say, here's the message, this is why X is bad or Y is good. So for us in designing that, we can, avoid bots if we're just looking at, let's say, people who have successfully quit smoking and want to know if vaping is a good alternative. Right, so we're going to see less bots, which might kind of cluster with commercial interests, right? With more of the small businesses and retailers kind of promoting products. And that's a particular group that, if we were designing these are the health effects, we'd avoid sort of that commercial audience and that sector. And even though, there will be people there as well, right? There's still going to be vape shop owners, there's still going to be retailers that are still people. But if we have a particular message we want to bring, which is, in this case, just health benefits or health problems, then we would look for groups that kind of identify or with their messages post about kind of questionable behavior, post more about, is this good for me? Is it bad? And we can see that, and those tend to be people that will cluster together. And that's how we sort of identify that and target an intervention that way.
And when you say you identify folks via clustering, can you talk a little bit more about how specifically you are identifying certain groups? I imagine you might use a number of different data sources in addition to who is in their network, but perhaps also things like their profiles or the content of their posts.
Yeah, and I think that becomes, again, platform dependent, right? Because, you know, as Megan pointed out, Facebook is much more, affords your identity to really be able to build your profile. And we've done, you know, the anti-vax work we've done, we've looked at that. We use that data when available because we get a lot of information about kind of those groups, and they do show up. Whereas with Twitter, where you just have, you know, this one sentence bio, we look at the content of posts, right? We identify the adolescents because they've talked about high school graduations and birthday parties, and, you know, then it's not going to be all vaping, right? Once we start seeing accounts that 100% of their posts are about vaping, we sort of kind of push that aside. But when we see little clusters and we can see, let's say 50, 60% of those accounts are talking about graduation parties and hanging out with friends at, you know, local places, we can sort of start making assumptions that some of these groups are more likely to be adolescents, are more likely to be less likely to be bots.
Great, thank you so much. And next, I'd like to turn to Megan and talk a little bit about the uniqueness of working with adolescents in the context of a social media environment. I mentioned earlier some of the ethical issues around working with teens comes up both in things like informed consent and in intervention delivery, as well as the potential of eliciting illegal or other high-risk behaviors on social media through our intervention work. So there's a specific question about how you used informed consent and how specifically you delivered it in the intervention with basics. And if there's anything you can talk about how much information they were asked to share via social media about their high-risk behavior or drinking, that would be great too.
Sure. So when I think about informed consent, I think about what is the age range of the study that we're doing. And I also think about what is the health behavior that we're doing. And I often think of this a little bit with my clinical hat. So when I think about when I see patients in clinic, and certain types of health behaviors are considered confidential care. So anything related to mental health, anything related to substance use, reproductive health, those fall under the rubrics of confidential care, where an adolescent can provide their own consent to seek care and to get care. And those rules and guidelines often they build the base of how IRBs think about whether adolescents are able to consent to be in a study. So if they're able to consent for their own patient care in that area or that health topic, they're often able to have a waiver of parental consent to do a study that aims to promote positive behaviors in those areas. So it often depends on what's the age of the folks we're working with, what's the health topic. An example would be, we did a study with younger teens working on improving fitness behaviors. And for that study, it was entirely appropriate for us to obtain consent from parents and assent from the teens. In the basic study, those were community college students, and they were all at or over the age of 18. And so for that study, we focused on doing individual consent with each participant. But if there had been adolescents that might have qualified for a waiver of parental consent because we were working with folks on a health behavior that would be considered confidential care.
We tend to take the same approach at Hopelab, so it's validating to see that that's how you all are thinking about it too. It's a little bit unique that confidential care issues might be state dependent.
Right.
And yet the recruitment that we're doing on social media is inherently not only single state focused, right? Great, thank you so much. And now I'd like to turn to Emily. There are a number of different questions around your correction of misinformation interventions. And so I'll pick one or two, and then folks can ask you other things in the networking session after if there's time. One person asks, what's the role of the platforms themselves in supporting positive behavior? And I imagine, you know, you've worked with a number of different platforms and that there's some variability there.
There's definitely variability. I would say that they have a big opportunity to use their systems to do a better job of addressing misinformation. So I talked about ways that they can use algorithms to respond to misinformation directly. The related stories functionality in Facebook is one of those examples. And Facebook has used that logic of providing additional context to any misinformation across their platform. So that's something they're implementing on Instagram as well. And I do think that's a promising solution, but it depends on recognizing the misinformation, and that can take some time. They've talked about it, between misinformation being shared and having the fact checks that they need, several days can pass. And they don't always have the motivation to do it as rigorously as we would like them to. So that's where I think a partnership between users and platforms could be really effective if algorithms could prioritize comments that are relying on high quality news outlets or high quality health organizations, comments that link to those rather than to some of the misinformation sites. That could ensure that those kinds of comments, those kinds of responses are being promoted. And we know that that kind of response can be effective in driving down misperceptions.
Mm-hmm. Great, thank you. And then there are a couple questions about the interventions themselves, i.e. the corrections, and then the user's receipt of the corrections. So around the corrections themselves, what can we do about correctors not following useful approaches? And what happens? Is there an intervention for correctors if I write something that's really not going to make so much of an impact? And then on the other piece is the receipt of that information. So how do you rationalize the fact that making corrections is subject to, our receipt of corrections is subject to confirmation bias? We want to hear what we want to hear, right?
So that's where I talked about the dual audiences for corrections. The person who shared the misinformation is going to be the hardest person to correct. They were convinced enough of a misinformation story that they publicly shared it on their social media feed, both of which puts up pretty big barriers to being responsive to correction, which is why I really want to focus on everyone else, sorry, my daughter, seeing the interaction on social media. And them being the more reachable audience. So there are cases where you correct somebody and they respond right away with, no, I'm right. But heuristically, people often are going to not pay a lot of attention and just look. And if you're providing high quality expert sources and the person sharing misinformation isn't, you're probably going to be more convincing. That's also where I suggest empathy can really help. We have all shared misinformation. Even I have done it, I am sure. So being empathetic and understanding and saying, I can see why you might be confused, but here's the most recent information from the CDC or something along those lines. We've shown that it doesn't harm the effectiveness of the correction, but it might make it something that people are more willing to do and more willing to accept. So to me, that just seems like a win-win.
Great. And then in our last 2 minutes, I'd love to ask each of the panelists, if I were a student coming to you and saying, I'd like to design an intervention to be delivered via social media for my thesis, and you have 1 minute left in our office hours, what would be one main thing that you would tell me to consider, to research further, or to keep in mind in launching this program of research? Let's start with Karhai. Sorry to put you under pressure. It was just first.
I understand. I'd say, and it's backwards of me as, someone coming from more a computer science training, I'd say have your, health theories in place first. Don't come to me with, I want to do this on Facebook, on Twitter, on Instagram. I want to talk to you more about, the framework and your theory, and then let's figure out where to put it and how to best do it.
Great, thank you. And Megan?
Yeah, I really love what Karhai said. To build on that, I think just being sure of why do you want to do it in this space, and are there unique elements of that intervention that would make it a good candidate for that, and really understanding how behavior change works and what these tools can do, and not reaching for it because it's kind of a new sexy tool.
Especially given that the new sexy tool will not be so new in about 2 or 3 days, and there'll be something else out there, right? The amount of times I've had to pivot in my studies is pretty amazing, as many as the number of studies. Thank you. And Emily, if you don't have too much noise in the background.
I would just echo exactly what both Karha and Megan said, thinking about what intervention is appropriate for which audience in which space. And I would also add, thinking about the mechanisms that are going to be consistent over time, because the technology will change. So what can you learn that you'll be able to use even when the next Twitter, the next Snapchat, the next Instagram emerges?
Indeed. Excellent. Well, it's been such an honor to moderate this panel. Thank you to all three of our panelists for giving everyone a sense of not only the breadth of what's out there, but hopefully some tangible strategies that we can think about in our own work and might be able to continue discussing with you all in the networking session. So Marika, I'd love to ask, you're already doing it, if you could bring up this slide for introduction to our virtual networking session, which is going to be starting in 1 minute. In order to meet any of the 2 experts that will be in each networking session, you need to go to a new and different Zoom meeting. The meeting IDs and passwords are up on this screen, and links to each of the rooms are also now in chat. So please choose network session 1, 2, or 3. You can leave this room and go directly to that next room whenever you're ready. The session will start at 10 a.m. PST, 1 p.m. EST, and it will go for 40 minutes. So there will be opportunities to continue the conversation that we started on this panel and ask the panelists more questions, moderated by other experts in social media research. We ask that you come back to this room, and links will be posted in the chat in the networking sessions as well, promptly at 10:40 PST, because we have rapid fire presentations that are short, sweet, and that you absolutely won't want to miss. Thank you all so much. It's been a pleasure, and see you in the networking sessions.